purpose of my lecture is really to tell us, where we are right now, what's the data, and then where we're going to be going soon, hopefully. Okay, so the way I have it broken up, whoops, it looks like the font's off, but we'll talk briefly about a background for EGFR mutations. We'll talk about current EGFR tyrosine kinase resistance, management for what you need to do now in your clinic, and then we're going to talk about our future, which is the novel agents that are targeting for these patients, the different new pathways and mutations that are occurring. And Mark did a great presentation already on MET inhibition, so I'll probably spend more time on the other groups of what I had listed on the outline. Now, everybody knows about EGFR mutations. Basically, the one thing I want you guys to remember is there are 3 mutations you absolutely have to know. The first is the deletion exon 19, the second is the L858 mutation, and then the third is the resistant T790 mutation. And the reason is that these mutations are not the same. Your deletion exon 19 mutants, we know that they're more sensitive to the EGFR TKIs, the erlotinib, gefitinib, what we have right now. These patients, you can get a couple of years, on these agents, and they'll do great before they develop any resistance. Ultimately, I suspect we're going to find out that the mechanisms of resistance for these patients are all going to be different depending on their EGFR mutation that they had de novo. So these patients, highly sensitive to erlotinib, gefitinib. Now, the L858 mutants, these patients also get that beautiful, partial response when you treat them with the EGFR TKIs, erlotinib, or gefitinib, but usually at about a year to a year and a half, these patients will develop resistance. It's almost guaranteed. So you got to watch these patients more closely. So there was a paper that came out in Science Translational Medicine by Letitia Sequist, where they actually took a group of patients who had the EGFR mutation, were treated with EGFR TKI, and then when they developed disease progression, they biopsied them. And so what they found out is sort of depicted here. As expected, about 50% to 60% of all of our patients who develop resistance develop that resistance mutation T790M. Now, the other groups were rather surprising. MET amplification was something that they found was in about 5% of the group. Also, they found small cell lung cancer transformation. So this argues for, again, doing rebiopsies on our lung cancer patients, which is a paradigm shift that we haven't done in the past. And then, of course, the PIK3CA mutation also occurred in 5%. And then 30% were of unknown mechanisms. So we still have yet to tease that out. Now, I'm going to come back to this pie chart a little bit later throughout the presentation. But I want to talk to you about the third mutation you have to know, which is the T790M. Now, this is a point mutation in the DNA codon that changes one amino acid, which changes one protein, that completely alters the binding pocket of EGFR. So you can't bind erlotinib or gefitinib anymore. Now, there are drugs that I'm going to show you a table later that are being designed for this new binding pocket that may potentially have benefit, the Clovis drug being one of them. But certainly, now that we understand the biology better, we can design our drugs better as well as target and get better clinical outcomes for our patients. Okay. But before we get to the future, what do we do right now in the clinic? Because we don't have access to these drugs right now. Now, obviously, as all of you already voted on, the patient who develops the oligometastatic disease, well, it's very obvious. You continue them on the EGFR TKI, and then you basically just radiate, or you could do surgical resection on that solitary MET. Now, typically, if it's contained in a field, for instance, if I have a patient who's got a couple mediastinal nodes that are growing, we will have our radiation oncologist radiate those nodes and keep them on the EGFR TKI. And these patients do extremely well. There have been several series of retrospective studies that have all shown additional progression-free survival benefit of 6.2 to 10 months when you do this. And there may possibly be an overall survival benefit. Again, these are all small retrospective studies, but one of them actually had an overall survival benefit, 41 months. So clearly this is a strategy that everybody in the room, I think, agrees on to go ahead and do. This is one of the retrospective studies published in JTO saying that not just for the EGFR mutant population, but also your ALK crizotinib patients who develop local regional, oligometastatic disease or local progression of disease, if you radiate them or do surgical resection, they will get benefit, both progression-free survival, potentially overall survival. Now, what happens, though, when you have a patient who their disease just basically explodes? And so, obviously, this is a patient who actually had an EGFR TKI, and they developed disease progression. And usually our standard paradigm is to take them off the EGFR TKI when they develop disease progression and then switch them over to something. But published in CCR was some data that maybe we shouldn't be doing that because there is definitely a flare response, just like in prostate cancer. When we take our lung cancer EGFR-mutant patients off the TKIs, their disease completely explodes out of control. If you reinstitute an EGFR TKI, sometimes you can reestablish control. Now, I'm showing you this clinical vignette to sort of set the rest of this discussion about what is the best thing to do for our patients right now. And I'm coming back to this pie chart. Now, obviously, in the molecular pathways, we don't understand yet enough, but we will. And ultimately, one day, I think it's going to be combining targeted agents about what their new molecular genetic abnormality is or what pathway got upregulated, and that's going to be the way that we handle it. But for right now, we basically have 4 choices. We can do chemotherapy, which is our standard paradigm. We could do chemo and then do EGFR TKI as maintenance, or we could do chemo plus EGFR TKI combination, or we could do intermittent. Now, I'm going to sort of give you the data that we have right now for each of these. But again, let me just preface this by saying we don't know what the optimal thing is. And ultimately, we may find out that depending on how they develop their resistance, as well as what their molecular genetic abnormality is, we may find out that one pathway works better than the other. Okay, so what we could say right now is in the clinic, all of these different paradigms are safe. And we know this because the Saturn trial, the Intact Tribute trials, and then the FAST-ACT studies. All of these have shown that we can do any of these to our patients after they've been treated with an EGFR TKI, and they'll be fine. It's safe. But what is the most optimal? What's in terms of efficacy? Well, let me give you the data that we have so far. Now, all of you already heard about the Saturn trial, both in Mark's lecture and Corey's. And again, this was the maintenance or erlotinib study. Now, this was not in the EGFR mutants. I'm just illustrating this because they did do a retrospective analysis looking at the EGFR wild-type patients versus the mutated EGFR patients. And these patients had an excellent hazard ratio, 0.1, the p-value highly statistically significant. So this strategy works for these patients. And who's to say that if you start off with an EGFR TKI, their disease, progresses, you give them chemo, and then you go right back to an EGFR TKI, maybe that will work for the patients. What about if you combine EGFR TKI plus chemo? Or, versus chemo. Well, there have been a couple of very small studies that have been done, and I put them all on a table. A lot of these are ASCO abstracts from 2012, and so, I do think the jury is still out, and there are a few studies that will hopefully, delineate more about this. But, for instance, the Goldberg study was looking at 44 patients who got chemo, and again, these are all EGFR mutant patients who had EGFR TKI, versus those that got chemo plus erlotinib, and they said the response rate was improved if you got chemotherapy plus erlotinib. One of the other small studies said that it actually could maybe improve survival, overall survival, and another one showed a fairly high response rate and disease control rate when you add chemo to the EGFR TKI. Now, is this evidence-based medicine? No. All of these are too small. They're retrospective studies, but it gives us a hint of what we can potentially do in the clinic right now. There is a trial, a phase 2 study called Aspiration, and this is an Asian study that will hopefully look at the difference between doing continuation erlotinib beyond the first progression. Now we're going to be talking about first progressions and second progressions, but their plan is to enroll 207 patients, and they'll see whether or not that actually has some benefit. There's some U.S. trials as well. Sorry, not U.S. trials. This one is actually Tony Mock and Jean-Charles Saurier. And this is looking at activating EGFR mutations that progress on gefitinib and then randomizing them to chemo plus gefitinib. And then Leona Horn at Vanderbilt is actually looking at a study where this one actually has activating EGFR TKI and EGFR mutants, and those who actually responded more than 4 months go on to this trial, and they get, again, chemotherapy plus erlotinib versus chemo alone. Now, we're going to find out more from these trials, but we don't have that data just yet. So what about intermittent EGFR TKIs, the FAST-ACT trials? Now, these were all predominantly done in Asia, and the only reason I'm bringing it up is because there is a theoretical concern that adding erlotinib to chemotherapy could potentially be antagonistic and not give you a good outcome. And the reason is that erlotinib usually arrests the cancer cells in the G1S checkpoint, not just erlotinib, all EGFR TKIs, arrests the cancer cell in the cell cycle at the G1 checkpoint. And chemotherapies typically work best when the cell cycle is in mitosis. And so the thought is there's potential antagonism here. So it first started off with a small trial, the FAST-ACT study of 154 patients. This was untreated lung cancer patients. They really didn't have any selection, but they were just trying to see, can this theoretically work? Is it safe? To give intermittent erlotinib on days 15 to 28 of a 4-week cycle, and then give the chemo during, it was platinum gemcitabine days 1 and 8. And then following up it with maintenance erlotinib versus placebo. And their primary endpoint, the primary endpoint was the 8-week non-progression disease rate, and so there really wasn't that much of a difference for the primary endpoint. However, when they looked at progression-free survival, they did actually say that the erlotinib-containing arm might potentially have a better hazard ratio for progression-free survival. So they went on to the FAST-ACT-2, which is the phase 3 trial. And this basically was, again, previously untreated, not molecularly selected, but looking at carbogem with erlotinib versus placebo. And again, the erlotinib was given intermittently so that there was no potential interaction of the chemo and the erlotinib, and then they got the maintenance erlotinib versus placebo. And the bottom line was that they did show that erlotinib had a better hazard ratio, 0.57, for the progression-free survival in the intent-to-treat population. And this was statistically significant. Now, I'm going to just throw in this caveat as a criticism of these trials. Now, the issue is that these trials all had the maintenance erlotinib. We know from the Saturn trial that maintenance erlotinib prolongs survival, progression-free survival for the EGFR-mutant population. Their hazard ratio I showed you was 0.1 and highly statistically significant. So whether or not intermittent erlotinib actually contributes to this progression-free survival remains to be seen. The benefit might be coming purely from the maintenance portion. So I think that these trials, although they were intended to answer the question about intermittent erlotinib, I don't think they have. But that is the data that we have currently. We do know you can do it. It is safe. There was no new toxicity signals that were seen. And certainly it is your choice if you want to do that with your patients. But that is, I'd say, we don't really know whether or not it's optimal. Okay, so to summarize, acquired resistance right now in the clinic for local oligometastatic disease that progresses or oligo-PD, continue EGFR TKI, apply local therapy. For more global progression of disease, you really do have 4 options, at least until we get some more data. And so you could do chemo alone, chemo plus EGFR TKI, chemo then EGFR TKI, or then intercalated. In my clinical practice, I generally will do one of these 2. And so I have on 2 patients done the intercalated EGFR TKI, but then the patients get confused about how to get, when to take the drug, and I'm tired of getting pages asking me, if this is the right day to take the drug. So just for ease, I do think those are 2 of the more practical strategies that we could do in the clinic right now. Now, ultimately, though, the patients will need rebiopsies, and a molecular profile will be generated, and then you'll give them a more targeted agent for whatever their mutation or pathway is. So very briefly, in the next 6 minutes, we're going to talk about some of the up-and-coming agents for this population group, and we're going to focus, I just picked these out because these are furthest along. We're going to talk about dacomitinib, afatinib, and then for T790 mutants in particular, the afatinib cetuximab trial. Now, you've seen plenty of tables. Mark did a great job showing you lots of new drugs. Again, the Clovis agent is very interesting, and you should watch out for that in the future. It's still very early on, but this is highly selective for T790 mutations. I don't have time to show you the initial preliminary data, but that is something to watch out for. The rest down here are just some MET inhibitors, because as you know, we've talked a lot about how MET pathway is important in EGFR TKI resistance. So beginning first with dacomitinib, this is an irreversible pan-HER inhibitor. It binds to EGFR, HER2, HER4. Main side effects are what you would expect: diarrhea, rash, stomatitis, paronychia. It does show high potency for her kinase inhibition, and there was a phase 2 study that compared dacomitinib versus erlotinib in the salvage setting, and it actually showed that it might potentially have a better efficacy there. So there's currently an ongoing phase 3 trial of dacomitinib versus erlotinib in salvage lung. This is, again, unselected molecular, okay? And so these patients, they are currently accruing to this trial, and we'll get more data. The dacomitinib is usually given at 45 milligrams daily. This is an interesting study for T790 mutations with the dacomitinib, and it's pulse dosing. And this is a phase 2 trial. So I don't know, they're only enrolling 30 patients, I think, and they're looking for 15 patients or more for the T790 mutation. So we may potentially see some data coming out, maybe not this ASCO, but then following ASCO. But this is an interesting agent to look out for. What about afatinib? Now, this one is probably furthest along, and unlike gefitinib and erlotinib, this is actually an irreversible ERB family inhibitor. And I'm just going to show you, I'm not going to go through all the trials, but I'm just going to show you the one, the LUX-Lung-3 phase 3 trial. Now, this is for patients who had adenocarcinoma who had an EGFR mutation in their tumor, and then they were randomized 2-to-1 to afatinib, which is given at 40 milligrams a day, versus chemotherapy with cispen. And the primary endpoint was progression-free survival. Now, this was a pretty global trial, and the bottom line was that the overall response rate favored the afatinib. Progression-free survival favored afatinib. And then when you look at the independent subgroup analysis, progression-free survival favored the afatinib across all the subgroups. When you look specifically at the molecular mutations, the common mutations, deletion on exon 19, L858, they all seem to get significant benefit with the afatinib. Quality of life analysis with the LCSS seem to favor the afatinib as well. So LUX-Lung-3 tells us that frontline afatinib seemed to improve quality of life, response rate, disease control rate, and median PFS over chemo in both the overall EGFR-mutant population and also specifically the common EGFR mutants. The subgroup analysis definitely should benefit across the board. There were no new safety signals. So I would say that afatinib joins our EGFR TKIs or erlotinib gefitinib, certainly in the frontline setting for our EGFR mutant population. But again, we're here to talk about resistance. So the reason I showed you the data on afatinib is to bring up this trial. So there was preclinical data that showed that for EGFR T790 mutants, the combination of afatinib and cetuximab might be effective. Now remember, cetuximab is a monoclonal antibody to EGFR, so it binds to the receptor on the outside of the cancer cell and downregulates it. The small molecule tyrosine kinase inhibitors go through the cancer cell membrane and they attach to the intracellular portion of the receptor, which is like the engine of the car, the ATP kinase binding region, and it basically stops cell signaling. So by doing a dual approach, the thought is maybe we might get better efficacy. So this was a phase 1 trial. They basically showed no DLTs at the afatinib at 40 milligrams a day plus the cetuximab. And then they had 2 different schedules for the cetuximab. And they're currently on an expansion cohort. But they have presented the data on the first initial 100 patients that were accrued. And in the red boxes are the T790 mutation patients. And you could see that they have a pretty decent response rate for a group that was probably insensitive to the EGFR TKIs, gefitinib, or erlotinib. So again, very early studies. We still have to learn more and get more data. There is a current ongoing phase 2-3 trial of afatinib plus cetuximab versus afatinib alone in treatment-naive patients who have an EGFR mutation. So we'll find out more from this trial and what we need to do. Now, I'm running out of time, so very briefly, because Mark already went over MET inhibition, I just picked this trial because it's the one that's furthest along. You know, everybody should look out for arnotezumab. I don't even know how to pronounce it, but METMAB is what we usually call it. Again, this was the phase 2 study results, and because Mark already showed it to you, I'm not going to emphasize anything except for the biomarker, which is a MET immunohistochemistry. That's diagnostic positive. If you have it, it does appear that you get a better response when you have the combination of the METMAB and the erlotinib. This is the MET diagnostic positive patients. And then if you don't have it, obviously you don't respond very well to the METMAB. Now, when we actually look at outcomes, it does appear to be a prognostic factor if you have MET overexpression. And so certainly that's something to keep in mind in our EGFR TKI resistant patients as well when we rebiopsy them and find out that MET is the pathway upregulated. Hopefully in the future we'll have MET-MAB or one of the other MET TKIs that we could use for those patients. The main toxicities that are different are peripheral edema. So, very important study. There's a phase 3 trial that is ongoing of MET-MAB plus erlotinib. And so it started enrollment in 2012. So I think, we might get some data hopefully coming in preliminary analyses over the next year. Okay, so what are my conclusions on clinical management for EGFR mutants with acquired resistance? Oligo-PD, continue EGFR TKI and localized therapy. Global PD, right now, we have a couple of different options. My personal preference is to do one of these two, just for practicality. But again, remember, we still don't know what causes resistance. So rebiopsying the patients, finding out what their mechanism of resistance is going to be a paradigm shift for us. And then selecting an agent that will target whatever that new pathway is critical. And so I'm going to just leave you with, this is my current treatment algorithm for a lung cancer patient that comes in through my door. But certainly this is probably in the next year what we're going to be looking at. And then, of course, once they develop resistance, they could easily cross over to one of these other. And this is, again, just the adenocarcinoma patients. But this is real, and it's happening. We're right at the forefront of this. And I think, the promise of this is certainly turning lung cancer from a fatal disease into something that is chronic. And so that would be a big achievement. I think that's well within our grasp. So I'll stop here, and thank you.